Good evening. I am Dr. Abhijit Trailokya, heading the medical department of Alchem Laboratories. Welcome you for Dapanam Conclave. So today's topic of discussion is SGLT2 inhibitor, cardio-renal benefits and beyond, and focus on Dapagliflozin. For today's discussion, we have international faculty with us, Professor Peter. He's from Copenhagen. Along with sir, we have national faculty, Dr. Bipin Shetty from Hyderabad, Dr. Tushar Roy from New Delhi, and Dr. Pramod Gandhi from Nagpur. To facilitate this session, we have moderator with us, Professor Chandalia, and he's from Mumbai. So welcome all of you for this Dapanam Conclave. Let me just take you through the agenda. So I will start the session, opening remarks and introduction of panelists. Then Dr. Chandalia will talk about context setting and SGLT2 inhibitor usage in India. Followed by Professor Peter will talk about SGLT2 inhibitor, cardio-renal benefits and beyond. Then we will take a few cases from Dr. Bipin Shetty, Dr. Tushar Roy, and then Dr. Pramod Gandhi, followed by a panel discussion, question answer session, and we will end the session by giving vote of thanks. For that, Mr. Pasha will give vote of thanks via of us. So let me take an opportunity to introduce Professor Peter, head of the Complication Research, Steno-Diabetic Center, Copenhagen, Professor of Endocrinology at University of Copenhagen, a past president of European Diabetic Nephropathy Study Group, president of Danish Endocrine Society, a member of the board since 2006, received many honors and awards as Mineralocorticoid Prize in 2005 from EASD 2012, Professor Vishwanathan Award, and many more. Published more than 500 publications, involved in several international studies in patients with overt diabetic nephropathy, aiming at improving the prognosis. He has been international and national investigator in various studies and cohort studies, member of steering group for Pearl NEGM 2020, the phase 3 renal outcome study, Fidelio and Fiagro, and flow on the treatment of diabetic kidney disease. Sir, welcome for this Dapanam Conclave. We have Professor Dr. Chandalia with us, and he's going to moderate the entire program. The Director, Diabetes Endocrine Nutrition Management and Research Center, Mumbai. Director, Endocrinology, Diabetes and Metabolism, Jastrow Hospital, Mumbai. Faculty, University of Alabama Medical Center, US. Faculty of Grand Medical College, Mumbai. Publication, 82 articles, original and review in scientific journal, 20 authorships and editorial ships, and great contribution to the books. Editorialship, International Journal of Diabetes in Developing Countries, then Diabetes Today since 1991, and editor-in-chief of RSSGI textbook of Diabetes 3rd edition, which was published in 2015. So welcome Dr. Chandalia for this program. We have Dr. Bipin Shetty with us. He's a consultant endocrinologist from Hyderabad, having more than 30 years of experience in medical profession. Was associate professor at Osmania Medical College, at Kurnool Medical College, and Gandhi Medical College, visiting faculty at National Institute of Nutrition, Hyderabad. He has several publications at national and international level, and he's a member of RSSGI, ISPAE, and ESI. Welcome, Dr. Bipin Shetty. We have Dr. Tushar Roy with us. He's currently working as a senior consultant cardiologist at National Heart Institute and Roy Heart Care Clinic, New Delhi. Senior resident and associate professor, PGIMER in 2001. Cardiology consultant, King Faisal Hospital, Saudi. Area of interest, preventive cardiology and medical legal law, and formerly honorary cardiologist at the Prime Minister of India. So welcome, Dr. Tushar Roy, for this program. And we have Dr. Pramod Gandhi with us. He's a secretary, Maha Endocrine Society of Maharashtra, executive committee member of Endocrine Society of India, organizing secretary for ESCON 2019, which was held at Nagpur. Past president of AMS in 2017 and 2018, Nagpur, and past president of Diabetes Association of India, Nagpur branch. Regional faculty for CCM, BDM, CCMTD, and AVG award. conducted more than 40 phase 2, phase 3 clinical trials in patients with type 2 and type 1 diabetes. So welcome Dr. Pramod Gandhi to this program. And now I request Dr. Chandalia to start the program by giving introductory talk. Over to you, sir.
Thank you, Dr. Abhijit. If I can have my slides, I got a very short time of 5 minutes to do the context setting. So I'm going to be very quick. We are trading familiar grounds, and of course we'll see more as the time goes. So next slide. Of course, we know multifactorial etiology of type 2 diabetes, and SGLT2 inhibitors were the first class of drugs which do not work through the insulin mechanism, while most others work through either secreting insulin, secretagogues, or insulin sensitizers. So it addresses another very, very interesting pathophysiology of type 2 diabetes. Next slide. Yes. Now, very importantly, the cardiovascular disease is the major problem in type 2 diabetes. As a matter of fact, diabetes is a vascular disease, so much so that once in a college cardiology department tried to take over complete diabetology, saying that it is nothing but cardiology, see. And with great difficulty, we defended the separate existence of diabetes as a subject. See, next slide. We know that almost 65% of type 2 diabetics will succumb to coronary artery disease or stroke or a cardiovascular death. And therefore, and of course, the disease is about 2 to 3 times as compared to non-diabetics. So all that is very well known. Now the cardio, so very, about a decade ago, or little before that, it was decided or it was thought that the drugs we use in diabetes should be either cardiovascular neutral or they should produce some cardiovascular benefits. So that was the beginning of the cardiovascular outcome trials for all the new drugs that were introduced thereafter. And therefore you see here a large number of studies here. On the top for the DPP4 inhibitors, and then at the bottom, all the studies are for the SGLT2 inhibitors. So the two very interesting group of compounds which were introduced somewhere 10, 12 years ago, and of course SGLT2 even less than that, you see, underwent these very, very interesting CVOT trials, very planned differently, statistical design is different, the way of interpretation is different than what we saw earlier, or at least I saw earlier in the classic studies like UGDP or for that matter, DCCT trials. So these are a large number of trials. Next slide. And what you really read, what outcome you see, next slide please. What outcome you see with the SGLT2 inhibitors, you see, is, and of course there are drugs which cause cardiovascular protection, and the SGLT2 inhibitor and GLP-1 receptor agonists are the two which came out as outstanding molecules in offering cardiovascular and renal protection as well. So these two very, very interesting aspects we are going to see today evening. Next slide. Yes. Now, SGLT2 have many potential protective mechanisms. And of course, a lot of them known to you. Natriuresis is a cause, and they may improve cardiac function. They reduce oxidative stress. There's some effect on glucagon. See, and of course, the effect on the glomerulus. Maybe they have effect on fibrotic process in the kidney, and so many other mechanisms which are being unraveled as we go along. But the clinical studies have shown clear benefits, and in fact, in a reverse mechanism now we are trying to find out why the benefit is primarily due to what action of these drugs. Next slide. Yes. The indications of SGLT2 inhibitors, you see, have gone a complete change in the past about 5 years or so. And in many countries, the regulatory bodies or the associations like Cardiology Association, Endocrinology, EASD, ADA, they have all emphasized the importance of these drugs and their early introduction, especially wherever there are cardiovascular risk factors or obvious cardiovascular disease. And approved indications, you see, some countries like ours, there is no clear approved indication or separate emphasis on introducing this drug at the correct time in the therapy of type 2 diabetes. However, many other countries, there have been clear indications or clear guidelines how to use these drugs and where to use these drugs. Next slide. Yes. Now, the impact on many risk factors, see, are very important, because if you're going to have good cardiovascular outcomes, they should control the risk factors very well. And we know obesity is a very major risk factor associated with type 2 diabetes. At least in our country, 2/3 of the patients that we treat are obese. And same thing is true in most of the other countries. And of course, hypertension is a constant problem in type 2 diabetes. So any drug which causes good glycemic control, which lowers the weight as well, and without much hypoglycemia and lowers the blood pressure, is going to be beneficial, because these are the risk factors that we know very well. Next slide. Now, what is happening to SGLT2 inhibitors in India? And they really they were introduced in India hardly 4 years ago. That's not even 4 years, 4th year is now running. And of course, you see, we have the 3 molecules very widely used in our country at the present time. And that is the Dapagliflozin, Dapagliflozin, and Canagliflozin. And number of patients treated is growing by every year. And of course, very, very importantly, Dapagliflozin losing its patent, the drug has become very inexpensive, and therefore now it is going to have a very, very important role in therapy of type 2 diabetes, because cost is an important consideration, not only in India, but now even the European guidelines, American ADA guidelines, they all now talk about the cost of the treatment. Next slide. And here is one of the guidelines, recent ADA, EST together, I think. And very importantly, when you're looking at patients from this angle, is there a problem with hypoglycemia? Is there a problem with obesity? Are there serious cardiovascular risk factors? Is there already a cardiovascular disease? These are some very important questions which arise in our mind when we think of choosing a drug for type 2 diabetes. And this has become very important approach as recommended by ASD. And this is AAC, Association of the Clinical Endocrinologists. And similarly, I think ADA and ASD have concurred with this approach. Next slide. Next, yes. The Cardiological Society here in their guidelines, as I said, they clearly mentioned that SGLT2 inhibitors, you see, are associated with low risk of heart failure. So this was the next. Besides the cardiovascular protection for 3-point MACE, which is usually myocardial, non-fatal myocardial infarction or non-fatal stroke, or cardiovascular death. A composite of this, sometimes a slight variation, has been used in all these studies of Empagliflozin and Dapagliflozin. And very interestingly, besides, of course, primary MACE benefits, these drugs have shown much more remarkable benefits in the kidney protection and in reducing the hospitalization for heart failure. Those 2 areas are new entrants now, last over only about 3 or 4 years, where a very important evidence has accumulated showing that the benefits, the renal and heart failure, are of the order of almost 30 to 35, 38% with these 3 SGLT2 inhibitors. Next slide. So people, the type 2 diabetic patients already having borderline renal problem, you see, and those are very large number if you see carefully in your clinic. There, you now use a different treatment approach. And although the SGLT2 inhibitors are contraindicated with below eGFR of 30 or certainly 20, some studies, but above that, and certainly above 45, you see, eGFR, they're considered very, very important drugs to be introduced in patients with CKD. Obviously, there has to be close follow-up initially whenever you introduce the drug with low eGFR, but subsequently you start, the benefit is seen after a few weeks' time. Initially, with slight lowering of eGFR, the benefits come out very, very beautifully. And as I said, from 30 to 38% or something of that magnitude, which is very important. Next slide. So in 2021, and we are marching into 2022 now. Next slide. What are we doing? So besides our classic approach of glycemic control, lipid control, you see, and blood pressure control, and tobacco cessation, and some of those obesity, those risk factors, I think the drugs which have come into the forefront in the cardiovascular and in the kidney area are of course, earlier were ACE and ARBs, and of course, now they're Neprilysin inhibitor, and of course, beta blocker is one of the early ones. Mineralocorticoid receptor antagonists are very important. And now, of course, we are today talking about SGLT2 inhibition as an important pillar in the treatment of type 2 diabetic with cardiovascular risk factors or cardiovascular events. Next slide. So these drugs, you see, so now the labeling process also has changed for some of these drugs, and some of the countries, there is clear labeling showing that which are the patients who should be, where the drug must be exhibited in order to give them the legitimate benefit which has been shown scientifically. Next slide. Next slide. Yes. And it is, you see, those established cardiovascular disease, you see, are very large number, and 1 out of 3 only, you see, is treated properly, or 2 out of 4, 10 is treated, besides glucose lowering, cardiovascular benefit is thought about. Next slide. So we have to intensify our approach towards cardiovascular and renal protection, and of course, the treatment, of course, the cost is a barrier in many places, in India certainly, except urban areas. I think poverty is highly prevalent even now, and patient pays from their pocket. So it is very, very important to have the products available, which do not cost as much. And as I said, you see, the Dapagliflozin losing its patent has been a blessing for people in our country. Next slide. So these drugs have gone through the initial stage of showing good glycemic control, and then came the cardiac benefits, and now we are looking at kidney benefits. And as we go along, probably later on, we'll see some other benefits of these drugs, which includes, hopefully, in the area of liver, which will be the next organ we'll be looking at in relationship to SGLT2 inhibitors, as well as DPP4 inhibitors, as to whether the NAFLD can be modified or retarded by these drugs. So this is the next approach, of course, which you will hear about in next about 3-4 years. So they see change in our approach to type 2 diabetes, which I have summarized for you. And this is going to unfold today evening in a subsequent program, where we are going to have a detailed talk by Dr. Peter Rossing from Copenhagen. And of course, he will be describing to us the cardiovascular and renal studies with Dapagliflozin. And then we have very interesting case discussion, highly relevant clinically, which you will enjoy looking at and thinking of answers in your own mind. So thank you very much. I look forward to the CME.
Thank you very much. Will you share my slides, or shall I share my slides?
So you can share from your side.
Okay. But thank you very much for the opportunity to be here today. Of course, it would have been great if we could have been together in a nice place in India. I have had the opportunity to visit your country many times, but hopefully soon it will be possible again. And you have said all the very important things, that we have a big problem and that we have new opportunities with new indications. I'll try to provide some more details to the underlying evidence or the studies that gave us these recommendations. But I think if you have just listened and learned from the first section, my talk is just an add-on. First, my disclosures here, and then, as we heard before, diabetes is, of course, a big and a growing problem. And these are data 2 years ago saying that 463 million would have diabetes around the country, around the world, and 700 million would be expected to have diabetes in 2045. And these numbers are already outdated. So now it's more than 500 million with diabetes and 785 million expected in 2045. And it's a large contributor to mortality that we have diabetes with 4 million deaths in 2019. And another important and frequent problem in our populations are chronic kidney disease. And although there are many people with diabetes, there are actually many more people having chronic kidney disease. So it's estimated that between 700 and 800 million already have chronic kidney disease. A major feature of chronic kidney disease, unfortunately, is that it's often undiagnosed because people are not screened for kidney disease. It is growing on the list of common causes of mortality globally. And of course, leading causes of kidney disease are, in addition to diabetes being the most frequent cause, also hypertension, which is also a very
Sorry
prevalent.
to interrupt you, sir. Your slides are not moving. It's
My
stuck.
slides are, okay, sorry. Let's see, I'll try again
So you
and
can
share my.
make it full screen and then run the slideshow. Then it will move.
Let me see. Do you see them moving now?
Yes, sir. Now it's moved.
Okay. Got. Okay, thank you. And sorry for this. This is the prevalence of diabetes. You will know that. This is the prevalence of chronic kidney disease affecting more than 700 million. And this is the problem with lack of diagnosis of people with diabetes. And even in diabetes, chronic kidney disease is often not diagnosed. These are data from the US. I don't know exactly how it is in India, but I feel it might be a similar problem that even in stage 3B with GFR 45 to 30, 30% are not diagnosed with chronic kidney disease. At least in my country, the situation is also not too good. So a big problem that we are not looking out for kidney disease. And those having kidney disease without diabetes is even more often not diagnosed. And when we look at treatment for kidney disease, either in diabetes or in non-diabetic kidney disease, it has for the past 2 decades or so not really been possible to find any new opportunities. We knew from 20 years ago where we had trials with ACE inhibitors, angiotensin II receptor blockers, that we had this as a standard of treatment in kidney disease, both with diabetes and non-diabetic kidney disease. And then for 20 years, all the trials we did with new drugs failed until 2 years ago, where we suddenly got trials with SGLT2 inhibitors, cretins, and later Dapagliflozin showing benefit, and also other compounds like endothelin receptor antagonist and mineralocorticoid receptor antagonist have recently shown benefit. So indeed, we are seeing more opportunities. And as you know, also the cardiovascular outcome trials that were mentioned in the previous talk have given us indications also for cardiovascular disease with the new diabetes drugs, or with some of them, the GLP-1 receptor agonists and the SGLT2 inhibitors. Talking about kidney disease, it's really important to look out for kidney disease, as I mentioned, because if you don't look out for kidney disease and make the diagnosis of kidney disease, you cannot make the right prognosis, but what is even worse, you cannot treat kidney disease. And now that we have drugs that are needed to treat kidney disease, like blockers of the renin-angiotensin system, but also now SGLT2 inhibitors, we really need to identify people with kidney disease. So we need to check not only eGFR by measuring creatinine in the blood, but also checking for albuminuria, as increasing albuminuria is a risk factor for progression of kidney disease, but also a risk factor for cardiovascular disease and an excellent risk factor for mortality. And we can do something about these risks by implementing the new treatment opportunities. And the connection between heart and kidney that was also mentioned is really important. If we have a failing kidney, we have a failing heart. And also reversely, if we have a failing heart, that will affect the kidney. And if we have a happy heart and a happy kidney, that's really good for our patient. And therefore, it is really, really great that we now have opportunities to treat diabetes that are good for both the heart and for the kidney. We actually had some trials developing new drugs where there was heart failure as a side effect, but now we have actually drugs that are both beneficial for heart failure and for kidney disease, and that is really improving the prognosis for our patients, as I'll just show you. And it's also really important, illustrated by this case, that initially we used the SGLT2 inhibitors and the other glucose-lowering drugs to lower glucose. And that is, of course, important. They are good glucose-lowering drugs, and SGLT2 inhibitors don't give hypoglycemia or weight gain. Rather the reverse, they introduce weight loss. But what is even more important, and you could say independent of the glucose-lowering effect, is the beneficial kidney and heart effects that have been seen. So now, not only early, where we can use SGLT2 inhibitors for lowering glucose, but also late we can use SGLT2 inhibitors. And as I mentioned, it's also important that initially we were taught that we could not use SGLT2 inhibitors in people with impaired kidney function because then they don't lower glucose. Importantly, they still have their organ protective benefits. So we should really use them down to and start them down to a GFR of 25, as I'll come back to. Partly because of this study. This was Dapagliflozin, the large dedicated CKD trial, chronic kidney disease trial with Dapagliflozin. It included type 2 diabetes with chronic kidney disease, but also as the first study, non-diabetic kidney disease, which was 1/3 of the population. GFR was in the range of 25 to 75, and all had albuminuria above 200 milligrams per gram, so high micro and macroalbuminuria, if you use that term. They were also all on standard of care, meaning ACE inhibitors or angiotensin II receptor blockers, and the study excluded type 1 diabetes and also polycystic kidney disease and some glomerulonephritis with lupus and ANCA nephritis, and ongoing immunosuppressive therapy were included. The trial was stopped early because of success, because the data monitoring committee said, this is so good that you need to stop. It was an international trial, global trial, also including participants from my country, Denmark, but also from India, a lot of participants from the US, from South America, so indeed a global trial. And the majority had diabetic kidney disease, as mentioned, but also some of those with diabetes actually had non-diabetic kidney disease as their cause of impaired kidney function or increased albuminuria. And you can see dominating of the non-diabetic kidney diseases are hypertensive nephropathy or IgA nephropathy, and also other causes of kidney disease, other glomerulonephritis, and some with unknown cause of kidney disease. And this slide illustrates on this KDIGO heat map where green is normal albuminuria, normal kidney function, where the cardiovascular outcome trials were in terms of mean albuminuria and GFR risk. So E for empagliflozin, the EMPA-REG trial, C for canagliflozin, the CANVAS trial, and D for DECLARE with dapagliflozin. These trials did include some with impaired kidney function or increased albuminuria, but the vast majority had a high cardiovascular risk or established cardiovascular disease, not kidney disease. So it was not until we got the first kidney-dedicated study, Credence, with patients with GFR from 30 to 90 or albuminuria above 300, that we got a kidney disease study with SGLT2 inhibitors, and then Dapagliflozin, including slightly lower GFR, slightly lower albuminuria, but a CKD population, and with a CKD primary endpoint as in Credence. And there's finally one trial ongoing with empagliflozin called EMPA-KIDNEY, which is different from Dapagliflozin and Credence, including a population with normal albumin excretion rate and GFR from 20 to 45. So an important subgroup to study because that's not really covered from the previous studies. As mentioned, Dapagliflozin was stopped early because of success, and Credence, the other SGLT2 inhibitor kidney trial, was actually also stopped early. So SGLT2 inhibitors are really, really powerful in chronic kidney disease with or without diabetes. These are the baseline characteristics of the participants in the Dapagliflozin trial. You see more than 4,000 participants, and age 60, and a majority of males. And as mentioned, 2/3 had type 2 diabetes. Fairly good control of blood pressure, and eGFR around 43, and approximately 900 milligrams per gram of albuminuria, and almost all patients were on ACE inhibition or angiotensin II receptor blockers. And the primary outcome was a 50% decline in eGFR, development of end-stage kidney disease, or kidney or cardiovascular death, and that happened in 312 cases in the placebo group, and in the Dapagliflozin group, it only happened in 197 cases, meaning a hazard ratio of 0.61 or 39% reduction, which is really a major reduction in this important endpoint. And you can see corresponding to a number needed to treat of only 19 for 2.2 years. So really a powerful result on this very clinically meaningful endpoint. And if you look on the components of this endpoint, you can see they are all going in the right direction. End-stage kidney disease, 50% decline in kidney disease, reduced almost 50%. Renal death, very rare event, whereas cardiovascular events were reduced with 19%, which was, however, not significant. Maybe because the study was not at all powered to see an effect on cardiovascular death, because it was stopped early and because it was only part of the primary endpoint. Interestingly, if you look into those with compared to those without type 2 diabetes, there's the same benefit, no significant p-value for interaction. And as you can see, actually if anything, a tendency towards a better effect in those without type 2 diabetes compared to those with type 2 diabetes. Also, the effect is independent of albuminuria level above or below 1,000 milligrams per gram. And then importantly, the effect is also independent of eGFR above or below 45. And this is important because, as mentioned before, below 45, there's no effect on glucose, but there's still a significant benefit on this important endpoint progression of kidney disease and cardiovascular or renal death. If you look into other subgroups, you can see it's also independent of age, gender, race, region, and blood pressure. So in that sense, it's really across the board that we see these benefits on the primary renal composite outcome. Another secondary outcome was cardiovascular death or hospitalization for heart failure. And here you can see a 30% reduction, which is in line with most SGLT2 inhibitor trials looking at heart failure. There is a reduction of approximately 30%, also highly significant. And if you look at all-cause mortality, which is an event which, of course, is very important, but rarely affected in clinical trials, you see a 30% reduction in all-cause mortality, also highly significant. So 45 events prevented out of 146 in the placebo group. So really, in this short time frame, yet this significant effect on all-cause mortality. What about safety? When you have a very powerful drug, it's of course important to look into safety. And as you can see, the safety profile, as we know it also from the cardiovascular outcome trials, is good. There's actually less discontinuation of study drug in the active group with dapagliflozin compared to placebo. And if we look overall at serious adverse events, that's also relatively balanced, and if anything, better in the dapagliflozin group. There's no increased risk of amputations. There's no problems with acute kidney injury, and there is no increase of fractures. And importantly, in the non-diabetic population, there was no ketoacidosis, there was no hypoglycemia, and actually also in the diabetes population here, there was no ketoacidosis. If we look at the different outcomes, I showed you before the primary outcome in those with or without type 2 diabetes. If you look at the renal specific outcome, which is similar to the primary outcome, but now without cardiovascular death, well, the benefit is also here similar with or without type 2 diabetes. Cardiovascular death or heart failure, also no significant p-value for interaction, and all-cause mortality is also similar with or without diabetes. Interestingly, if we look at the effect on hemoglobin A1C, there is a small effect on hemoglobin A1C in those with established type 2 diabetes. The effect is smaller than in other trials. That's of course because the GFR at baseline was not very high, only 43. In those with pre-diabetes or normal glycemia, there is no effect on hemoglobin A1C. If we look at the primary outcome, the primary outcome, also the end-stage kidney disease outcome of 50% decline in eGFR outcome, they are again independent of glycemia status. Now here, normal glycemia, type 2 diabetes, and then the non-diabetic group is split also into those with pre-diabetes, where we see similar benefits. What about the effect according to baseline eGFR? Approximately 35% had stage GFR less, as you can see here to the left. 44% had GFR 30 to 44, and 14% had a GFR less than 30. And they were split as in the overall population. Those with stage 4 CKD, meaning less than 30, they were split 1/3 non-diabetic and the rest with type 2 diabetes. And again, if we look, those with stage 4 CKD, they had similar benefit for the primary endpoint, the kidney-specific endpoint without cardiovascular mortality, the heart failure, and the all-cause mortality endpoints. We see exactly the same benefits also in those with GFR less than 30 to start off. So this is important that we should remember to start also those with advanced kidney disease, and we don't see any increase in adverse events in those with CKD4. One of the concerns with starting in very low GFR patients has been a discussion around the initial dip in eGFR, which is seen in all studies. But as you can see, this dip in GFR is smaller if baseline GFR is smaller. So here in those with stage 4 CKD, the dip is only 1.4 milliliters per minute on average. compared to 2.6 in those with 45 in eGFR at baseline. So suggesting that we should not be concerned that if you start with a GFR of 27, you will end up in dialysis because of this initial dip. That is not seen in any of the clinical trials. Interestingly, I showed you this benefit was independent of albuminuria and GFR. And if we go back to the cardiovascular outcome trials, then you can see that actually in the cardiovascular outcome trials, the kidney composite endpoints were seen in those with completely normal GFR, with GFR 60 to 90 or 45 to 60 or less than 45. So consistent benefit across these different studies on kidney outcomes. These events were not very frequent in these populations because it was cardiovascular populations, but as you can see, quite consistent benefit independent of GFR. And also, if you look at different albuminuria strata, you can see that even in those with normal albumin excretion below 30, you see protection of kidney endpoints with exactly the same hazard ratios as in those with elevated albuminuria. So that's coming back to the interaction that if we have a drug that's good for the heart, it's good for the kidney, and vice versa. But what was the status of cardiovascular disease in the DAPA-CKD population? Well, 37% had any degree of cardiovascular disease at baseline. Heart failure was prevalent, but also myocardial infarction, stroke, or a history of bypass or stenting was quite prevalent in this population. And if we look at the outcome with or without cardiovascular disease, well, you can see both the kidney outcomes and the cardiovascular heart failure and cardiovascular death outcomes and the all-cause mortality outcome are seen whether you have cardiovascular disease or not in this population having CKD. If you look at those with heart failure at baseline, that was approximately 15% of the population. Those with heart failure had a much higher risk for all the endpoints, but the benefit on the kidney and secondary outcomes and all-cause mortality and heart failure hospitalization was seen both in those with and those without heart failure. So the relative risk reduction was similar, no significant p-value for interaction for any of these groups. All-cause mortality, I mentioned, was reduced 30%, and that's really rare. So it would be interesting to see what are they actually dying from in this study. And it's interesting to see that more patients are actually dying from non-cardiovascular death to the right than cardiovascular death, where sudden cardiac death is dominating. And you can see infections and undetermined causes of death are quite prevalent. And when we look at the effect of dapagliflozin, there is an effect on, as I mentioned, death from any cause, but there's actually an effect. This effect is driven more of the effect on non-cardiovascular death and perhaps on the heart failure death, and not so much sudden cardiovascular death, no effect on stroke or myocardial infarction. So interesting, and I think these data needs to be confirmed in other studies before, and we need to understand the underlying mechanisms for why we see these benefits. And coming to mechanisms, we heard in the first talk a little bit about mechanisms, and there are indeed many suggestions for the potential mechanisms for kidney and cardiovascular benefits: the glucose lowering, the weight lowering effect, the blood pressure lowering effect, the diuretic effect, the reduction in intraglomerular pressure may be important, and maybe the decreased reuptake of glucose and sodium leads to less oxygen consumption, and that may also be an important driver of the kidney benefit we see with the SGLT2 inhibitors. And that may explain why we have seen across a wide range of populations seen benefit of the SGLT2 inhibitors. And here with dapagliflozin, we saw it in DECLARE, we saw it in DAPA-HF with existing heart failure with reduced ejection fraction, the DAPA-CKD that I went through. We have seen benefits on cardiac and renal outcomes. That led to the KDIGO guideline. I was part of the group devising this guideline, and you saw it in a different way before, but really stressing that in chronic kidney disease and diabetes, we use metformin for glucose control, SGLT2 inhibitors that will have a glucose reduction effect if you have preserved renal function, but not if you have a impaired kidney function. And it's really important to think of the SGLT2 inhibitor here more as an organ protection, as a kidney protection and heart failure protective drug than as a glucose lowering drug. And the complete or comprehensive care of management of kidney disease and diabetes could be emphasized like here with in the bottom: lifestyle, exercise, healthy nutrition, smoking cessation, then control of risk factors of glycemia, blood pressure, and lipids, then RAS blockade as we have seen it for many years, and now SGLT2 inhibitors should really be there for their potential glucose lowering effect, but particularly because of their kidney and cardiovascular protective benefits. And then you may give antiplatelets to some as well. Unfortunately, despite this is on the guidelines, despite we have seen these cardiac and renal protective benefits, we are not applying these agents. And that is really the dilemma. We need to screen for kidney disease and diabetes. We need to identify patients and start these therapies. These are data from the US of patients with chronic kidney disease and diabetes, where less than 1% in 2019 are treated with a GLP-1 receptor agonist or an SGLT2 inhibitor. Some other countries have better data, but in my country, it's approximately 25% of those with cardiac or renal disease that are treated with an SGLT2 inhibitor or GLP-1 receptor agonist, but still it should be much, much better than that. So I really think that's really where we as physicians need to do, that's a key task, to identify those at risk and implement therapy. Therapy which is not implemented or guidelines that are not implemented will obviously not work. So finally, I'll just show you this, which was very recently published, that not only is the cardiac and kidney protection glucose lowering effect, there's also prevention of diabetes. And this is data from the DAPA-HF and DAPA-CKD non-diabetic populations, where we see a 33% prevention of diabetes in the Dapagliflozin group. So indeed, many, many opportunities. And as we heard, in the future, maybe liver will be another opportunity. But to sum up my talk, remember to look out for kidney disease, look out for diabetes, not just by screening for EGFR, but also albuminuria. Dapagliflozin has shown beneficial effects on heart failure, on kidney outcomes in type 2 diabetes with risk factors, and we have seen beneficial effects on kidney outcomes, heart failure, mortality as well in chronic kidney disease. And these effects have been extremely consistent across all the subgroups we have looked at, and it's now implemented in the guidelines. Please also make sure that you implement it in therapy. Thank you very much, and I look very much forward to the discussion we are going to have now.
Chanel, you need to unmute yourself.
Yeah, Abhinav, would you like to take over? We go to the case discussions. And then, would there be any questions to Dr. Rosing? Abhijit? Yeah, Dr. Shruti.
So shall I present my case? Thank you. I think we had a very lucid discussion on the points around the SGLT2 inhibitors in general and also in comorbidities. I would be presenting a situation wherein they are indicated and might be of use even without comorbidities. We have a 55 years housewife who took VRS from the bank she was working. She's self-reliant and she's going to the United States to be with her son's family after the demise of her spouse. She has to be looking after the 2 children, grandchildren, and was detected diabetic on workup. She's about 2 months' time for stabilization before departure, and BMI is 29.6, HbA1c is 8.2, LDL is 104, eGFR is more than 90. She's normotensive. We are focusing on glycemic control. It's quite clear that she requires to manage her weight, as also her LDL requires high-intensity statin. But that's not the focus of discussion today. Her HbA1c being about 8.2 and the target for her being certainly less than 7. And if you're using anti-hyperglycemic therapies which do not cause hyperglycemia, maybe 6.5, what would be the choices for glycemic control? Monotherapy or combination therapy? The answer is quite clear. She's unlikely to reach the target that we have in mind for her with just one drug, so we would like to give her combination therapy. And what might this combination therapy be? Which of these combinations will get her to the target HbA1c, conservative target of 7, or anything that's beyond? Metformin with SGLT2 inhibitors, metformin with GLP-1 analogs, metformin with DP4 inhibitors, and any of the above. In fact, any of these agents will be able to get her to the target. GLP-1 analogs would have some issues of cost, which might be a case in her since she wants to fund her treatment her own self and she's going to pay out of pocket, but any of these combinations will get her to the target. Regarding which of these drugs will get her to target without causing hypoglycemia, again, all of these drugs have the potential of achieving the target safely without causing hypoglycemia. If she is looking for weight loss, which is the case, and lifestyle modification is going to be certainly helpful, which of these drugs is going to help her? And here we have just these 2 drugs which can help her reduce weight. D4 inhibitors, while they will help her reach the target, there is no benefit in terms of weight. Now, if this woman was, say, 60 years or older, and she has dyslipidemia, she would be a person who was similar to the population of declared TIMI. And then there would be a proclivity to use SGLT2 inhibitors in her, along with metformin, though there is some data around the use of GLP-1 analogs in primary prevention cohort of the injectable drug, the dulaglutide. Now we have this situation wherein the ADA-AHT guidelines outside the domain of comorbidities like ASCVD established or risk factors for ASCVD, heart failure, DKD with or without proteinuria. You have the role for SGLT2 inhibitors in areas where you can have the potential of minimizing hypoglycemia, where they share the space with D4 inhibitor, GLP-1 analogs type the TZDs, and in our country, alpha-glucosidase inhibitors. Alongside GLP-1 analogs, these are the only drugs which produce meaningful and significant sustained weight loss. Cost is an issue because the drugs are more expensive in the Western world, but they are certainly cheaper, and with the availability of certain low-cost generic Dapagliflozin molecule, this issue is also not a consideration. Certainly, they're not as expensive as the GLP-1 analogs, even when they're available in the oral route of administration. So in brief, then, the choice of the agent for glycemic control it has many options. We look at efficacy, cost, lack of hypoglycemic potential, safety, and the possibility of use in comorbidities, beneficial effects on weight, etc. And these do influence the choice, as we have discussed. SGLT inhibitors are having a place beyond their preferential use in comorbidities, as has been discussed with the data based on the DKD and the heart failure trials. The additional advantages, I'm not talking just about the blood pressure and uric acid lowering, but we're looking at hypoglycemia and weight loss. There are additional reasons for their expanding role in management of type 2 diabetes mellitus. And with that, I thank you for presenting this case. Over to the second speaker.
Thank you. Thank you very much. Good evening, friends. I will be presenting a case to highlight some of the points being discussed. So this is a 63-year-old lady who is known to suffer from coronary artery disease and has heart failure with reduced ejection fraction. She is not a diabetic, but is a known hypertensive and hyperlipidemic. And she has presented to us in the OPD with mild breathlessness on FR. If you see her current medication, she's being treated for coronary artery disease with atorvastatin 80 milligrams a day and aspirin 75 milligrams. Atorvastatin is a good choice because if you see on the right, she does have some chronic kidney disease with a calculated eGFR of about 50 ml per minute per meter square per 1.73 meter square body surface area. Regarding the heart failure, actually, she's being pretty well treated with beta blocker metoprolol, AC inhibitors lisinopril, spironolactone, and her symptoms are being managed with furosemide. Yet she has now presented with some heart failure with mild breathlessness on FR. Her vitals and pertinent lab reports are that her pulse rate is 74 per minute, blood pressure is 118 by 74, creatinine is 1.2, which gives a calculated eGFR of 50 ml. Sodium is 136 and potassium is 4.2, they're normal. Next slide, please. So how can we improve her situation? How can we improve the heart failure? And what's the current guidelines that we can implement in her to give her the best outcome? What about tolvaptan? Tolvaptan is actually not really indicated here because the sodium level is normal. In any case, if there was hyponatremia, that would have been dilutional hyponatremia. So tolvaptan, not a really good choice here. How about furosemide? Increasing furosemide? Well, furosemide would actually improve her breathlessness, but it will not improve the outcome. The outcome is not improved with furosemide. And also because the blood pressure is on the lower side, it may paradoxically lower the blood pressure even more. What about isosorbide dinitrate hydralazine combination? A good combination, an old combination, but it's not one of the major pillars of treatment now in heart failure with reduced ejection fraction, but can only be used as a backup measure only when other measures fail. What about dapagliflozin? Absolutely. Dapagliflozin is probably the right agent to use in this particular patient. And we'll be looking at why that is so. Next slide, please. So you see, the story started with rosiglitazone. Sometime in the year 2008, when there was a meta-analysis that said rosiglitazone was causing excess of myocardial infarction. This prompted the FDA, the drug regulatory authority of the United States, to put rosiglitazone on hold for some time and issue a strange mandate. And that mandate was that all new anti-diabetic medication must have cardiovascular safety data. This was something new that was implemented by FDA, and then started all the cardiovascular safety data with DPP-4 inhibitors, which we know are cardiovascularly neutral. And these trials started coming up with SGLT2 inhibitors. So in 2015, EMPA-8 came, more than 7,000 patients, followed up for over 3 years. And these are patients that all of which had cardiovascular disease, all of which has diabetes, but none of them had heart failure. And the surprising thing was, if you look at the right column, there's a lot of numbers in this, but if you look at the right column, heart failure hospitalization, and concentrate on the HR, the hazard ratio, you find that there was a 35% reduction in heart failure hospitalization. This was something new. This was not what was expected. What they were trying to show was that empagliflozin was safe as per the FDA mandate, but here they found that actually it was causing a benefit. There was less heart failure hospitalization. 2 years after that, in the CANVAS program, more than 10,000 patients, now followed up for a period of 3.6 years. And in this case, 2/3 of them had established cardiovascular disease. 1/3 did not have established cardiovascular disease. All of them had diabetes. None of them had heart failure. And in that, in the right side column, we see that the heart failure hospitalization was reduced again by the similar amount, 35%. Surprise, surprise. This is something that was not expected. Then came the Declare TIMI 58 trial, more than 17,000 patients, followed up for about 4.6 years. 2/3 of them were primary prevention. That means 2/3 did not have cardiovascular disease. All of them had diabetes. None of them had heart failure. And here also we find that approximately around 30% was a reduction in heart failure hospitalization. This was something surprising. This was not there. So people started thinking, why not actually use dapagliflozin in patients with heart failure? Why don't we use it as a treatment for heart failure? And so 2 other trials were tried, the DAPA-HF trial, which has already been talked about, and the Emperor reduced trial. So these 2 trials, in the first trial, DAPA-HF trial, more than 4,700 patients, followed for about 18 months, showed a decrease in heart failure hospitalization of 30%. Emperor reduced trial, beta blocker / ivabradine pillar. The beta blocker / ivabradine pillar. So that's the first thing that we start. Along with that, we start an SGLT2 inhibitor. It doesn't matter whether the patient has diabetes or no diabetes. Even in patients without diabetes, as we saw in the DAPA-HF, SGLT2 benefit. And therefore, that's the second line of pillar to be started along with beta blockers right at the beginning in patients with heart failure with reduced ejection fraction. After 2 weeks, we follow up the patient, do the necessary workup, and we add either AC inhibitor or ARB or ARNI. Now, most of the cardiologists are not going through the AC inhibitor first, followed by ARNI step. We are going direct to ARNI. That means we are bypassing the AC inhibitor step and going directly to ARNI. So we are starting sacubitril valsartan in our patients, 50 milligrams twice daily, and then increasing it to 100 milligrams twice daily. Very few of our patients actually need 200 milligrams twice daily to manage their cases. So most of the Indian patients, they are requiring 100 milligrams twice daily. 2 weeks after that, after monitoring the blood pressure, after monitoring the potassium level, we are now introducing the 4th and final pillar, that is the MRA, the Mineralocorticoid receptor antagonist, which is either spironolactone or eplerenone. Mostly we are using spironolactone 25 milligrams or eplerenone 25 milligrams, mostly spironolactone 25, simply because of the cost. And we are reserving eplerenone for later use, especially if they develop side effects with spironolactone, and that is if they develop either nipple pain or gynecomastia. So these are the 4 essential pillars that one must be on, and the physician must answer why the patient is not on this if after 4 or 6 weeks the patient is not on any of these 4 pillars. Next slide, please. So just to reiterate again, if we start with a beta blocker and we maximize the dose of beta blocker could be metoprolol, beta blocker could be carvedilol, it could be bisoprolol, or even nebivolol in elderly patients. And we either maximize the dose of beta blocker or we use the maximum tolerated dose of beta blockers. And if despite that, the heart rate is more than 70, then we can add ivabradine. So that's the beta blocker ivabradine pillar. Along with that, we add the SGLT2, either dapagliflozin or empagliflozin, to be added at the same time. 2 weeks later, we go direct to ARNI. That means we start the sacubitril valsartan, 50 milligrams twice a day, and hike it up after a couple of weeks to 100 milligrams and so on. And then 2 weeks later, we add the 4th and final pillar, that is the MRA, spironolactone 25 milligrams. So next slide, please. So in this particular patient, we will be treating coronary artery disease with aspirin and atorvastatin, which she was on already. Furosemide, of course, we will continue. And as her symptoms improve, as her breathlessness improve, we will actually be reducing the dose of furosemide, because furosemide only affects symptoms, it does not affect outcome. So let's see what the 4 pillars are there for the heart failure management. She's on beta blockers, that's the first pillar. Dapagliflozin has been added, which is the second pillar. Then thirdly, she was already on lisinopril. And therefore, we are switching her over to sacubitril valsartan, ARNI. But before doing that, we must make sure that patients who are on AC inhibitors must stop the AC inhibitors for 36 hours. And so for 36 hours, we stop lisinopril and then switch over to sacubitril valsartan. That's a 3rd pillar. And finally, she was already on the 4th pillar, spironolactone. We continue on the 4th pillar of spironolactone. And I'm sure with this kind of medication and with the adjustment that we will do in subsequent weeks, she will do much, much better. So that's it, folks. Thank you very much.
So thank you, sir, for the
diagnosis and yearly thereafter. Patients with diabetes and urinary albumin excretion more than 300 mg per gram of creatinine or eGFR of 30 to 60, in these patients should be monitored more frequently, maybe at least twice a year. We should also evaluate this patient for presence of any medications which probably affect the renal functions, maybe NSAID. Sometimes ACE inhibitors or ARBs can also worsen the renal functions, that we will discuss. Aminoglycosides or radio contrast agents can, if any of these agents are there, that should be removed. And the management is based on three pillars: glucose control, blood pressure control, and reduction in proteinuria. The glucose control, optimal glucose control should be achieved, but then we need current ADA guidelines says that we should select a drug which has more renal benefits in terms of reducing the progression of renal failure, and SGLT2 is found to be associated with proven benefit in patients with CKD. Even GLP-1, if patient is not getting any benefit or glycemic control is not achieved with SGLT2 inhibitor, then probably you can add GLP-1 receptor agonist. Dapagliflozin study has clearly shown the benefit which we have already heard. In patients with CKD with increased risk of cardiovascular event and CKD progression, or those who are unable to use SGLT2 inhibitors, in these patients probably MRA, mineralocorticoid receptor antagonist, should be used. Patients with CKD with albumin creatinine ratio more than 300 mg per gram of creatinine, a 30% reduction or greater is expected or recommended to show that there is slowing of chronic kidney disease progression. And optimization of BP control is also equally important, either to prevent, to reduce or to slow the progression of CKD. ACE inhibitors or ARBs are recommended in all patients with diabetes and hypertension, recommended for those patients with moderately elevated urinary ACR, but it is strongly recommended if ACR is more than 300 mg per gram of creatinine or eGFR if it is less than 60. We need to monitor serum creatinine and potassium level at regular interval if patient is on ACE inhibitors or ARBs or diuretics. However, do not discontinue ACE inhibitor renin-angiotensin system blockade, that is AC inhibitors or ARBs, with minor changes in the serum creatinine level, that is less than 30% changes in the serum creatinine level. If it is there, don't stop the ACE inhibitors or ARBs. People with non-dialysis dependent stage 3 or higher CKD, dietary protein restriction should be advised, and patients on dialysis, higher protein intake is advised to prevent the catabolic stage. In our case, patient has stage 3C, stage 3B, A3, so her patient's eGFR is 32, which is just borderline. If eGFR is less than 30, we recommend to stop metformin. So in this patient, either you can stop metformin or reduce the dose to 50%, but then in that case we need to monitor these patients more frequently, maybe monthly. We should monitor patient for progression of the kidney renal CKD progression, or else we should use alternative anti-diabetic drug, maybe meglitinides or maybe insulin. We can add SGLT2 inhibitors. Currently, ADA recommends that SGLT2 inhibitors can be given to patient with diabetes with CKD whose eGFR is more than 25. However, KDIGO guidelines says if it is eGFR is more than 30. But then the DAPA CKD has clearly shown that benefits of Dapagliflozin were seen if eGFR is about 25. We should also add ACE inhibitors or ARB to this patient to control her blood pressure. ACE inhibitors and ARBs are not recommended for the primary prevention of CKD in patients with diabetes who has normal blood pressure, normal urinary ACR or normal EGFR. It is not recommended. It is not going to show any benefit. Patient should be referred for evaluation to nephrologist if EGFR is less than 30. Prompt referral to nephrologist for evaluating other causes of renal failure should be done if they are suspected strongly. Thank you. Thank you for your patient hearing.
Thank you, sir. It was a really great discussion, case discussion. So now I request all the panelists to join because there are certain questions which we got from the audience. Also, I request Dr. Peter's opinion on that. So, a question from Dr. Mahesh. He wanted to understand what are the common side effects associated with SGLT2 inhibitor and special focus on Dapagliflozin and how to tackle the side effects.
Yeah, thank you. That's an important question, of course. And as I mentioned, the actually more people on placebo stopped the treatment than on Dapagliflozin. But the common side effects are genital infections, which is seen with some patients with SGLT2 inhibitors, and good hygiene with frequent or regular daily washing is recommended to prevent that, and that is quite successful. The more important, serious side effects that have been seen with SGLT2 inhibitors have been diabetic ketoacidosis. That is very, very rare in type 2 diabetes. And as I mentioned in DAPA-CKD, it was actually not seen, and it was not seen in the non-diabetic populations. But there has been some of the SGLT2 inhibitor trials like Credence where there was more diabetic ketoacidosis, but again, it's really, really a rare condition. But it is important to be aware in the emergency room if you have a patient treated with an SGLT2 inhibitor coming in, because it may fool the physician if you're not aware of this normal glycemic ketoacidosis that you will have because of the SGLT2 inhibitor. But that is a rare thing, so not very important. More frequent problem is probably volume depletion, particularly in areas where it's very hot. And in that situation, of course, good instructions in hydration is important, but also important to remember that even though there is this effect on volume, there's actually 25% less acute kidney injury with the SGLT2 inhibitors than seen with placebo in the different trials. So although there is an effect on volume and you should be careful in very warm areas, there's not more acute kidney injury. So I think overall it's a remarkable safe drug considering the many important benefits we have seen, and with these effects as most important to remember to inform patients about.
So thank you very much. Anything want to add from panelists, sir? Dr. Bipin Sethi, Dr. Tushar, Dr. Chandalia.
I would like to comment on a couple of things. One is that if you get not mycotic infection genital, but urinary tract infection, then to restarting it, as they recommend after about a month or so, I would never practice that. The reason is all these patients are already having recurrent UTIs. And quite often these are postmenopausal females which devitalize the perineal area. And I don't think I would attempt again if somebody had an overt and bad urinary tract infection. And secondly, the ketoacidosis, those of us, many of us practice only ambulatory endocrinology and diabetes, but I practice in the hospital. And every year now we are recognizing about this year, last year we recognized 6 patients who were sick and where the SGLT2 inhibitor was not stopped by the treating doctor. So when they landed, they had a ketoacidosis. See, moderate pH of about 7.2 and in the end the hydroxybutyrate raised. So those of you who practice acute medicine, be careful. You'll see this. You'll see this, and you'll have to really tell patients any sickness they have to stop this medicine. Yes, medicine, but first to be stopped when the person is sick. The person is sick with any illness, diarrhea, vomiting, gastroenteritis, which is so much common in our country. I think they should be told to stop the medicine.
Thank you, sir. Sir, there is a question on similar line, and doctor wanted to understand what is the percentage of electrolyte imbalance with SGLT2 inhibitor, whether you have to worried in geriatric population or not.
No, I mean, if I should start, actually, we see in the heart failure trials less hyperkalemia if you combine, for instance, spironolactone or other mineralocorticoid receptor antagonists and SGLT2 inhibitors. So you see a small reduction in risk for hyperkalemia. Hyponatremia is usually not a concern. And then you see a uric acid lowering effect, which is usually considered a benefit. So I think actually we have a drug that is very safe in terms of electrolytes, and where we actually may see an opportunity to mitigate the risk of hyperkalemia seen with some of the other drugs, also ACE inhibitors, ARBs, or the new finerenone may cause hyperkalemia that can be reduced with an SGLT2 inhibitor. The only maybe concern there has been is in the combination with large doses of loop diuretics and SGLT2 inhibitors. And it's not because it has been a major problem, but in some of the initial case series or small studies, there were people having dehydration because of the combination of SGLT2 and loop diuretics. But in the larger trials, there has not been any recommendations that you need to stop or reduce doses of loop diuretics. But in many guidelines, that is mentioned as something you should consider if you are on high doses of loop diuretics to consider lowering the dose, but it's actually not what has been done in the trials.
So I think Dr. Pramod Gandhi want to add something, sir, requesting you to please continue.
Thank you. In hospital setting, there was one more thing which I feel which we had seen recently, especially during the second wave of COVID, when a lot of patients were put on steroids, where we should stop using SGLT2 inhibitors because they are already bedridden, they are on steroids, their glycemic control gets worsened, and then chances of getting recurrent genital mycotic infections are very common in such situations. So in COVID patients who are hospitalized, there are very few admissions in the third wave. That's a fortunate thing. But then we should be careful if patients are on steroids. We should avoid using SGLT2 inhibitors.
Yes, interesting that last year at the American Diabetes Association annual meeting, there was a study presented with Dapagliflozin in COVID-19 patients, where there was actually no significant harm, but also no significant benefit. But the trend was actually towards a benefit and not harm. So at least the presenters concluded that it seems to be safe. I don't know, however, how many of these patients were getting prednisolone. So in that sense, I think your advice is well taken and important to be aware of.
Sir, one more question which we got from audience. Any updates on this dapagliflozin in preserved ejection fraction?
Well, there was a smaller, I mean, there's a large study running in heart failure with preserved ejection fraction with dapagliflozin, which is not ended yet. There was a smaller study with dapagliflozin looking more on quality of life metrics that showed benefit. But what we are really waiting for is a study similar to the Emperor Preserved, but run with dapagliflozin, and that should come out soon, as far as I know.
So I think Dr. Bipin Shetty want to add something.
Yeah.
Yes.
I think both Dr. Gandhi and Dr. Peter have raised a relevant point. But the study population in the DARE study was that which was not admitted, which was not having low oxygen saturation. So they were not really sick. So what the study proved was that if somebody is ambulatory, staying at home and on SGLT2 inhibitors, they can be safely continued. That's all that we can conclude. But it was not given to sicker patients. So the advice of Dr. Gandhi is quite relevant, because whether or not the patient requires steroids when they're sick, even otherwise, one would not be either continuing and, of course, leave alone starting these therapies. So SGLT inhibitors can, if somebody is ambulatory stable, as is the case in the third wave with Omicron, that people are maintaining their oxygenation, they're not requiring hospitalization, and their glucose levels are okay, and the person has previously been on SGLT inhibitors, then they can be continued. But to initiate this is a little bit dicey, and we don't have sufficient evidence to say that in hospitalized patients, certainly, even otherwise, as was discussed by Dr. Chandalia, these drugs could possibly be the first ones to be taken off when inpatient hyperglycemia is a concern. So I guess both sides of the coin are there, but in more serious patients, I think one should not initiate and certainly discontinue the SGLT inhibitor. That's what I feel, and that's what we have been practicing.
So, thank you, sir. Any opinion from Dr. Tushar Roy in terms of usage in preserved heart?
Yes. I totally actually agree with Dr. Peter, and that has been our experience also, that while treating patients with heart failure, reduced ejection fraction, actually SGLT2, when we start using it with beta blockers, it actually prepares the ground for introduction of spironolactone. That means the hyperkalemia that we notice is actually lower. So that's also one of the reasons why we start with SGLT2 right at the beginning, to prepare the ground for introduction of ARNI and to prepare the ground for introduction of spironolactone. Also, as mentioned by Dr. Peter, I'm also in strong agreement that as we introduce these 4 pillars, the patients start improving symptomatically, and we have a tendency of reducing the furosemide, the diuretic. We do not like to continue diuretic. We like to come down to the minimum amount of diuretic that will help preserve the symptoms of the patients. Regarding preserved ejection fraction, yes, now we have 2 pillars and perhaps 3 pillars. Recently, other than empagliflozin, the spironolactone has been, following the TopCat trial, the spironolactone has been approved by the FDA in a slightly controversial decision. And also in selected cases, the ARNI has also been, proven to be beneficial in patients with preserved ejection fraction. But we are looking forward eagerly to dapagliflozin and its role in heart failure with preserved ejection fraction.
So I think we came to the end of the session. So first of all, thank you, Dr. Peter, then Dr. Bipin Shetty, Dr. Pramod Gandhi, and Dr. Tushar, and definitely Dr. Chandalia for wonderful discussion on SGLT2 inhibitor. For giving vote of thanks, now I wanted to request Mr. Shashi. He's heading the marketing team of Metabolic, and requesting Shashi to please join us for giving vote of thanks.
Thank you very much, Dr. Abhijit Saab, for giving this opportunity to give vote of thanks at the end of such a wonderful session. First of all, I would like to greet all the eminent doctors present here, Professor Peter Rossing, Professor H.B. Chandalia sir, Dr. Bipin Shetty sir, Dr. Pramod Gandhi sir, and Dr. Tushar Roy sir, and all the eminent audience who are present here from across the country. 2,428 doctors, they are registered to attend the program, and almost all of them have logged in to attend this program. 2,400 the number speaks volume about the interest all the audience they had shown up in the topic, and because they were also excited to hear to all these eminents present here, starting from Professor S.B. Chandalia sir, Professor Peter Rossing sir, Dr. Bipin Sethi sir, Dr. Tushar Roy sir, and Dr. Pramod Gandhi sir. Sir, I would like to say here, sir, since the day I have spent 18 plus years in the industry, since my initial days of my career, I have heard a lot about all these eminent doctors who are like gurus in this therapy, diabetes management therapy. Whether Chandalia sir or say Bipin Sethi sir, you all are gurus and eminent legends in diabetes management across the country. Pramod Gandhi sir and Tushar Roy, the same holds true for you, sir. I have heard a lot about you from my initial career days. And regarding steno diabetes research, the day I started my career, steno, the landmark studies which has been done in complications in diabetes, whether microvascular or macrovascular complications, these are landmark trials which have saved management approach across the globe. So a huge thanks to you, Professor H.B. Chandalia sir, for moderating the session, sharing your expertise, experience for the benefit of society at a large, for sharing such wonderful insights, sir. Thank you very much, Chandalia sir, for moderating the session so well. Thank you, Professor Peter Rossing, for sharing all your global expertise, global experience, more than 400 plus the trials which I had heard, the more than 400 plus publications which you have hold regarding complication in diabetes, cardiovascular and renal complication. And thank you very much from India for sharing your global experience with all of us. Thank you, Bipin Sethi sir, for sharing your expertise, experience and insights. Being a senior eminent doctor in this therapy, it will add immense value to the audience who are watching this program, sir. Sir, your names, Bipin Sethi sir, Pramod Gandhi sir, Tushar Roy sir and Professor Peter Rossing, Professor Chandalia sir, your names attracted the audience to listen to this session. Thank you very much, Bipin Sethi sir. Thank you, Tushar Roy sir, for wonderful case study, sharing your insights, unique observation regarding Dapagliflozin. Thank you, Pramod Gandhi sir, sharing your insights through case study as well as highlighting the importance point of managing diabetes during COVID also. And thank you very much, all our dear doctors who are attending across the country. We have this wonderful molecule Dapagliflozin with the brand name Dapanom. We say new normal in diabetes. Dapagliflozin got off patent during this new normal, and our brand Dapanom offers new normal therapy, as you all, even Professor Peter Rossing said, this is new normal therapy in diabetes. So we request all of you to trust Dapanom, the brand of Dapagliflozin in India from Alkem. And we once again thank you, a heartfelt thanks to all of you. Thank you very much for attending this program, and thank you very much for sharing your insights. Thank you very much, all the eminent doctors. Thank you, sir. Thank you. Thank you, sir. Thank you. Thank you, Dr. Saab. Thank you, Dr. Avijit, for moderating the session. We are very much grateful to you. Thank you very much. And thank all our colleagues from across the field, all our DSM colleagues, RBM colleagues, field managers, ME colleagues who have connected with all our audience across the country and gathered 2,500 doctors to attend this program. Thank you very much, all doctors. Thank you very much, all our dear colleagues. Thank you, Swapnil, and thank you, technical support team, for supporting for this program. Thank you very much, all. Thank you, Professor Peter Rossing, once again. Greetings from India. India loves you, sir. Thank you, sir. Thank you very much. We'll close the session. Thank you very much. Thank you, Tushar sir. Thank you, sir.